So today I'm going to be talking to you about sagging eye, and the most common cause of the sagging eye is the sagging eye syndrome. So as you know, the gravitational field of the planet is pulling down on everything, including your lid. And so for the lid, the age-related eye finding of the eyelid is levator dehiscence. So it's not really a dehiscence, it's just stretching because the elasticity of the tissue is giving way. So when we're looking at patients who have this kind of levator dehiscence, they have a high lid crease, which is indistinct because that's where the levator inserts into the skin. And it's going to have a deep superior sulcus because that superior sulcus is up here, and that's representing the age-related fat atrophy that is seen in elderly patients. And their levator function is usually going to be good. So we shouldn't really have an impaired or loss of levator function. The pupil, of course, has to be normal. And in the sagging eye, the motility finding is usually a very non-specific thing, but it's also age-related. And it's going to be an esotropia, age-related esotropia, and it's going to be greater at distance than at near. There's also going to be a small hypertropia or hypotropia, depending on whether it's the lower eye on the right or the higher on the left, they're the same. And there's going to be some excyclotorsion in that eye as well. This is going to be the cyclovertical strabismus component of the horizontal age-related esotropia at distance in the sagging eye syndrome. And so radiographically, what we see is normally the superior rectus, the inferior rectus, the lateral rectus, and the medial rectus muscle form like a cross here to elevate and abduct and adduct the eye. But when you have the sagging eye syndrome, this band between the superior rectus muscle and the lateral rectus muscle is just like the levator. It gets a dehiscence, so it gets stretched out. And so then the whole thing rotates over. So we have inferior displacement of the lateral rectus, and we got medial displacement of the inferior rectus. And so the muscle's no longer in this cross formation. That rotation of the muscles leads to the movement of the lateral rectus pulley system. And when you have a displacement of the lateral rectus muscle pulley, the mechanical advantage created by that pulley has been changed. And so we get a small angle esotropia and an associated hypertropia with a small angle excyclodeviation. The Deduction and inversions, of course, are going to be full, and you really shouldn't have any saccadic slowing or velocity drop in the movement of the eye because it's not really a ductional neurogenic problem. It's a super common cause of small angle deviation, esotropia, and small angle hypertropia in elderly patients, and may be one of the most common causes of diplopia in elderly patients. The key and differentiating feature is the rotation and the stretching of the superior rectus lateral rectus muscle band, and the movement and inferior displacement of the lateral rectus and its pulley. The treatment, strabismus surgery, but you could try prism first, as with all patients with strabismus. And it's benign. You can image it, but we're usually just imaging it for the muscles. That means MR of the orbit. However, if you want to do the head, it's fine. And nothing causes it. It's an age-related phenomenon. So the most common cause of the sagging eye, both the sagging eyelid and the sagging eyeball, is the sagging eye syndrome.